All right. We have about 10 individuals who have indicated an interest in making a presentation to minimize the amount of just time between each present. We're going to have the presenters come up here. So I'm going to announce two at a time, the first one. So if the second person would just come close so that we can minimize the time, then we can have time and each presenter should talk for 2 minutes. Hopefully that will give us enough time for some questions back and forth if some of the committee members might have that time. So again, 2 minutes, and we have our timer in the front. So Stephanie, I'm sure I'm going to mispronounce some of these names. Ahmed, who's the president of the Massachusetts Coalition of Nurse Practitioners, on the topic of removing barriers for advanced practice. So,
Thank you very much. I appreciate the
Hold on for 1 second. And Brittany, if you could come up. Brittany, you're fantastic. Thank you.
Ready?
Yes, please.
Perfect. Okay. So thank you. On behalf of the Massachusetts Coalition of Nurse Practitioners and the more than 8,000 NPs practicing in Massachusetts, I really appreciate the opportunity to present before you this morning on the importance of the IOM report in our initiatives in the state to remove an antiquated model of a Nurse Practice Act that requires physician oversight for our prescriptive practice as well as joint promulgation, which requires that the Board of Registration in Medicine jointly promulgate the laws around advanced practice. This model is replicated only in Massachusetts, Alabama, and Delaware. We have legislation pending right now, our second filing to remove that, with the hope to better position our state to meet the overarching objectives of health reform, the triple aim. Massachusetts has long sought to be a healthcare leader, commencing in 2006 with our enactment of universal coverage. That legislation certainly received national recognition and served as the template for the later enacted Affordable Care Act. So what have we learned in paving the way? To underscore the importance of the Future of Nursing report, universal coverage does not translate into universal access to care. A recent Merritt-Hopkins physician recruitment survey demonstrated that while we boast the largest number of physicians per capita in the country, we have the largest number of wait times, and patients across a variety of specialties are waiting significant delays with care, upwards to 100 days for primary care in some geographies. In 2008, the Mass Legislature determined that practicing as a primary care provider was within the scope of practice for NPs and adopted a law to ensure that insurance carriers would list us in provider directories. A recent trip to the Division of Insurance supports that Blue Cross Blue Shield, the largest insurer in the state, has registered only 7 NP PCPs in the city. NPs are performing millions of patient care visits in Massachusetts, and we remain invisible and unselectable as a high-quality, cost-effective care option for patients. By 2010, the legislature recognized that because credentialing healthcare providers is necessary to get paid for services rendered, and that discriminatory processes for certain licensure types were common, they mandated uniform credentialing.
Can you bring it to an end, please?
Okay. So I think there are a number of issues that are happening in Massachusetts. Universal credentialing was never enacted. We have nurse practitioners who are paying $500 a month for physician supervision, which constitutes a retrospective review and doesn't contribute to patient safety. We have instances...
Can I ask it to end, please?
Oh, sure, absolutely.
Because there's just a lot of people ahead of you.
Okay, absolutely. I'm sorry, I thought I had 3 minutes when I was told to prepare my comments.
All right, I apologize, but...
Thank you.
Okay, I'm sorry, but we have a lot, and because I want to speak to you after. You and I have a common element here. We're going to do it together.
I hold you to that.
I am.
We're going to do it together, right?
Okay, Brittany.
Thank you to the committee for this opportunity. My name is Dr. Brittany Broyhill, and I'm an acute care nurse practitioner. I'm the fellowship director for the largest NP postgraduate program in the country at Carolina's healthcare system located in Charlotte, North Carolina. Beginning in October 2013, we have successfully implemented fellowship programs for nurse practitioners across the continuum of care in 16 different specialties and are still growing. We graduate 56 new fellows each year, most of whom remain providers within our healthcare system and have become the top NPs in their specialty, as well as leaders within advanced practice nursing. As a founding member of the Association of Postgraduate APRN Programs, I'm pleased to offer support for the inclusion of NPs in recommendation number 3. We do not agree that these programs challenge the clinical abilities of nurse practitioners, but can only enhance their performance, especially clinicians and nursing professionals, and offer the following support based on our experience and outcome measures. The existence of postgraduate programs does not promote the requirement of completion of these programs for practice. No further costs are created, as these NP fellows are billable providers and can generate revenue for the practice that they're learning in. There are certain specialties in which extended orientation is not feasible and in which basic NP education does not prepare an NP. An example would be CT surgery. New graduates need extensive skill training that cannot be accomplished under full salary productivity demands. They need protected time to learn their skill without productivity requirements and in a provider role. Each of our programs have seen a significant demand for this training, as evidenced by the number of applicants to each position. Our next cohort at CHS had 253 applicants for 28 positions. Additionally, most of our fellows are top students from nationally renowned NP schools. I offer the following outcomes from my own programs. Our fellows have demonstrated a statistically significant increase in clinical knowledge and perceived preparedness to perform as an independent care provider. 100% of our fellowship graduates report that they would complete the program again, given the choice. There has been an increase in participation in professional organization of our fellows. We have retained 81% of our trainees into our healthcare system. And finally, we have had a major return on investment to our organization with decreased turnover rates, decreased recruitment cost, and an increased advanced clinical practitioner workforce when prior to the fellowship we could not find enough qualified applicants to meet our system demand. In closing, a fellow North Carolinian, Dr. Tom Bush from UNC, just completed a research study in which he demonstrated that graduates of postgraduate NP programs are more satisfied as providers than those who did not complete a fellowship. More satisfied NPs are clearly necessary in the face of a tumultuous healthcare environment that has providers leaving the practice of medicine. With IOM's backing and recommendation, funding opportunities are more likely to develop so that we can support NPs that are so desperately needed to care for our nation. Recommendation number 3 is vital for the development and continued success of postgraduate education for nurse practitioners. Thank you.
Thank you very much.
Sue, could we just ask, can you send us any information on?
Yes, that's good. Thank you.
Absolutely. I also have cards here that I can be happy to share with the committee.
All right, thank you very much, Marcy. Marcy Farquhar Snow, who is the director of the Cardiology MP Fellowship Program in Mayo Clinic.
Hi, thank you. We have a 12-month postgraduate cardiology nurse practitioner fellowship. In addition to primary care, there's a lot of specialty needs for highly trained nurse practitioners. And we are funded by Mayo School of Health Sciences. Since 2009, we've graduated 9 fellows. 100% of them have continued on in a cardiovascular area. Only 40% are retained by Mayo Clinic, but that's not a goal of our program. Instead, we want them to continue in a cardiovascular field. 22% of them are diverse graduates, and they are employed as an employee of Mayo Clinic with benefits. They rotate through their subspecialty areas and are assigned to mentors. Those are in an interdisciplinary team, so that can include pharmacists, it can include physicians, echo sonographers, and they are a part of the faculty and the evaluation process. That way everybody is kept accountable as well. Our goal is to communicate what is the role and scope of practice of the nurse practitioner in the cardiovascular area, and that really comes through well with the program. The benefits of it is that they are mentored, they get lifelong learning, and they get consistent exposure to all these different areas that they may not have had the opportunity in their academic practice. So they're a visible part of the interprofessional team. We are accredited by the American Nursing Credentialing Center, and that helps validate their rigor and competency. Those are developed from the NOPFI and the ANA CV cardiovascular scope and standards, and also in association with the American College of Cardiology. We keep in contact with them as well. So what we would like to see is that fellowships maybe are also incorporated into our academic programs and possibly be part of their capstone project, so we can fully integrate those nurse practitioners who want to excel in a specific area of concentration of their career, similar to other professions such as pharmacy and medical model that have fellowships and residencies. Thank you.
Thank you very much. Is Frank Purcell? Again, and if Renee could come up and get close to the mic, that'd be great. Thank you. So Frank is from the Senior Director of the Federal Government Affairs, American Association of Nurse Anesthetists.
Dr. Altman, Dr. Stith-Butler, members of the committee, thank you. We also want to express appreciation to Dr. Donna Shalala and the members of the committee that developed this first report on the future of nursing, recognizing its title and recognizing, as Dr. Curley of the Jonas Center had put earlier today, and Dr. Room as well, that the title of the report serves to impair the ability of certain sectors in the health industry to hear its findings. And we'd like to urge, on behalf of the American Association of Nurse Anesthetists, that the committee consider deeply that the additional factor that shapes healthcare delivery is not solely teams, not solely nurses, not solely physicians, in fact, not solely patients, but systems of payment and of reimbursement. And some of these issues are described in the written statement of the American Association of Nurse Anesthetists and our national president, Sharon Pierce. But reflecting on some of the discussion that has taken place, it's well understood that in our field, nurse anesthetists do provide the full scope of anesthesia services and provide pain management for an enormous population in the United States. And yet today, payment systems effectively impair patient access to the services of nurse anesthetists and support and promote inefficiency. They promote discoordination. They fail to recognize the providers delivering care, and they fail to have a relationship adequately with excellent outcomes and with quality healthcare delivery. Fortunately, there is today, in the 5th year of the Affordable Care Act, and at the time that the Congress has just passed the Medicare Access and CHIP Reauthorization Act, hope and opportunity for change that we believe that the committee's action can help to influence and support. The committee should be in communication with major health plans, the first of those being the Medicare and Medicaid plans, so that they adopt policy to promote the recognition and advancement of the roles of advanced practice nurses, including CRNAs. We should also as well recognize that changes in healthcare payment include the adoption of high deductible health plans. They have their pluses and minuses, but one of their effects is that they certainly make patients more interested in the overall price cost of healthcare delivery, and perhaps even more interested in the quality of services that they're getting for their money. At a time when we're expecting Medicare populations to nearly double by 2030, at a time today when we are today spending twice as much per capita on healthcare and not living twice as long or as well, the opportunity for improvement is great. The fields are ripe, and the committee has an opportunity to influence positive change. Thank you.
Thank you very much, Frank. So, Renee, and if Ruth can come up and join us. So, Renee, Frank is a Doctor of Nursing Practice student at the University of Maryland.
Thank you very much. Appreciate the opportunity to share some remarks. I am a DNP student at the University of Maryland, and I've been doing my scholarship work in the area of nurse residency, and so I'd like to share a few remarks in that regard. We know that the period of transition to practice is a very unstable time for the entry-level nurse, and we see evidence of that in our turnover data. And Christine Kovner's work has been quoted repeatedly about the high rate of turnover among entry-level nurse. But what we know is that the introduction of nurse residency programs have helped to reduce this high rate of turnover among entry-level nurses. And we had a robust session yesterday regarding nurse residency. And I've been active with the Maryland Statewide Collaborative with regards to advancing the IOM recommendations with regards to nurse residency in the state of Maryland. And I'm also a member of the Regional Action Committee in Maryland, and we recently met to talk about how we could continue to advance the IOM recommendation. And there were two areas that we want to focus on that we would like to express here. And one has to do with going beyond looking at the number of nurse residencies and really looking at the substance and the nature of those nurse residency programs. So while we recognize that the number of nurse residency programs have increased, what we're asking for further examination of is what is the actual nature of those nurse residency programs. An additional matter for consideration is to look at accreditation. While we know that there are hundreds of nurse residency programs across the nation, there's a paucity of programs that are actually accredited by a professional organization. And nationally, there's only 21 nurse residency programs that are actually accredited. And so this really compromises our ability to communicate to our community of stakeholders the fidelity of nurse residency programs to adhere to standards of practice. And so I would like to close and just ask that the committee continue to support nurse residency program for transition to practice. They not only serve the purpose of promoting competency, satisfaction, decreasing turnover rate, but they're an investment in our practitioners in an effort to promote quality as well as effectiveness of care. Thank you.
Thank you very much. Okay, so Ruth Lubick, who is the founder of the Developing Family Center program, and she's a nurse midwife.
I'm credited with starting the first freestanding birth center in the country in 1975. And I would like to urge Adrian to give my remarks made at the May 28th meeting, which covered a lot of the needs of birth centers, which have now grown to 300 in number, as well as the remarks that I drew up for this. And I want to tell you an anecdote. I am an honorary black woman. Now, why should I be an honorary black woman? Let me tell you that when the tobacco money came out in this town, we were urged to partner with another not-for-profit to bring them out into our neighborhood. And we talked, the boards talked, the staffs talked, and it seemed like a very good idea. The other not-for-profit was an organization called Bread for the City, which gives away food big time. And so we were moving along toward making that arrangement. And I said one day to the director, I said, George, we haven't asked the women. And he said, well, you're right, Ruth, we haven't. So suppose I send one of our vans around and we can take them to show our other two settings what we do. And so we did that. I didn't go with them because I had seen them before. But when they came back to the Developing Family Center and went into the conference room, I walked in and I said, well, and the women said, now who thinks they know why the women would have said that? I will tell you why. Because they were afraid for their babies. They went and looked at these settings where there are many kinds of mentally ill, drug-addicted people hanging around outside, and they were afraid for their babies. And that's something that we as health professionals can't really determine unless we talk to the people. So I am advocating for a culture of health.
Thank you so much. All right, Susan Stone. Again, if Elaine Ryan can come up closer so that we can benefit from, you get an extra 1/10 of a minute.
Hello, my name is Susan Stone, and I'm a certified nurse midwife and also the president of Frontier Nursing University, which is a not-for-profit, single-purpose university located in Kentucky. Frontier Nursing University has a 75-year history of graduating nurse midwives and nurse practitioners who are specifically prepared to provide rural health care to rural and underserved families. We transitioned to delivering the education to nurses through distance education in 1989. We currently have 1,500 students enrolled, and they are located in every single state in the United States. By offering distance education and partnering with community-based preceptors, we are able to reach those nurses who work and live in rural areas and would not be able to relocate to obtain a graduate education. In fact, 78% of our current students reside in federally designated rural counties. Our diversity initiative, which we implemented 5 years ago, has increased our underrepresented student population from 9% to 15%. During those 5 years. We hold institutional accreditation from the Southern Association of Colleges and Schools and programmatic accreditation for each of our programs. Since the publication of the Future of Nursing report, we've made great strides in increasing our number of graduates. In the last 5 years, we've graduated 638 nurse midwives, 912 family nurse practitioners, 155 women's healthcare nurse practitioners, and granted 176 Doctor of Nursing practice degrees. Of those graduates, approximately 300 entered with an associate degree through our ADN to MSN Bridge program. We strive to provide a high-quality education at an affordable cost for nurses who want to obtain a graduate degree and provide service in their communities. I will close with that. Basically, my point is that we do need innovative models of education, particularly if we're going to reach out to the nurses who live in rural areas and give them an opportunity to seek a graduate education and advance their careers. Thank you.
Thank you very much. Okay, Elaine, Ryan, and if Ann Kurth could come up closer. Thanks.
Good afternoon. I am Elaine Ryan. I'm the Vice President of Government Affairs, and I lead a team that advances our state advocacy in the 50 states, the territories, and the District of Columbia. Shortly after the issuance of the IOM Full Practice Authority recommendations, AARP incorporated those goals into our policy and included the objective of removing barriers to practice as a part of our organization-wide dashboard goals. Working together with the Center to Champion Nursing in America and the Campaign for Action, we integrated scope of practice into our work. We identified relevant legislation, produced issue briefs, led coalitions, and advised legislative staff of the need for reforms. And we are making real progress. Since the start of our efforts, 8 states, Connecticut, Maryland, Minnesota, Nebraska, Nevada, North Dakota, Rhode Island, and Vermont, have removed statutory barriers that prevented nurse practitioners from providing care to the full extent of their education and training. And these victories have increased access for consumers. This is not a battle between nurses and doctors. It's providing greater enhanced access for the consumers who need it. These barriers make little sense at a time when consumers are in need. Allowing APRNs to directly provide care helps to ensure consumer access to primary care clinicians when and where they need one. And it reduces the weight of care for consumers and their caregivers. We put this initiative as a part of our family caregiving campaign. As a caregiver for my mom and pop for over 15 years, I saw firsthand how these barriers to scope of practice limited my family's access to care. My mom would have to travel the whole day to go 8 blocks to a doctor's office for a simple change of medication that Nurse Sue, who was her visiting nurse, could have done so easily. It's time to remove the outdated barriers that prevent nurses from practicing to the full extent of their education and training. And as I say in my Twitter account, it's time to give nurses more authority to heal. Thank you.
Thank you very much. Ann? Ann Kurth is from New York University College of Nursing.
Thank you. I really want to acknowledge the tremendous work of the committee. I am also the incoming Dean of Yale School of Nursing. So I appreciate the chance to briefly present some thoughts from actually some of our community at Yale School of Nursing regarding IOM recommendation number 3 around nurse residency. This is from Lisa Corbett, who's one of our current DNP students. As we've discussed, there's been progress made in support for BSN entry-level nurses, and we've just discussed that with clear impact on good outcomes. However, the same support is not evident for APRN entry level into the workforce. We did discuss yesterday with Dr. Flinter the issues around primary care, NPs in primary care, but for the other range of APRN practice, including specialty care, there is a need for this, and we would ask that the committee consider endorsing in its collation of gaps the idea of best practice APRN institute models. To assist with onboarding, competency assessment, evaluation, and retention issues with the transitioning of new APRNs. Moving to IOM key message number 3 around full partnership. This is from Caroline Pacelli, who is one of our YSN DNP grads. Nurses are passionate and invested in creating sustainable evidence-based models customized to their population. So we feel that, again, that the IOM committee has an unprecedented opportunity to provide recommendations related to critical success factors of population health nursing and partnering with other national organizations around this. Dr. Pacelli has chaired a National Association of Healthcare Quality work group to identify public health competencies, and that's going to be published shortly, and we will share that with the committee. Closing with recommendation number 1. This is from our Executive Deputy Dean, Holly Kennedy. Tremendous shortfall of OBGYNs in the U.S. Half of all U.S. counties now don't have an OBGYN. Midwifery is the logical answer in meeting this gap. So again, we would ask the committee to consider recommending investment in graduate education for midwifery and nursing. The Lancet report recently did a special issue on the power of nursing. They declared midwifery and nursing. Midwifery is a best buy in primary care and has a return on investment that's equivalent to childhood vaccination. So there is an organization of 7 midwifery organizations called MIRA, represents all 7 of the U.S. midwifery organizations, who have done a Delphi study. They've drafted a joint consensus statement on principles of model legislation and regulation, and that will be made available to the committee as well. Thank you.
Thank you very much. So now we're going to show a video that is coming from both Diana Ruse and Diane from the Center for Health Systems on personal efforts and medical center activities. So I don't. Okay. Okay. Technology. Okay. So I'm going to open this up if this isn't. So is there any questions that any of the committee members wants to raise for any of our speakers that made a presentation? And apologize. Yes, Bob?
My question was...
Where's the mic? Is there a mic?
my question is for Renee Franquise about, you said that there were 21 credentialed residency programs. Is that what you talked about nursing and about ARNP? Are those ARNP programs or are those nursing residency?
Post-baccalaureate. There
Post-baccalaureate.
are 17 accredited through the American Association of Collegiate Nursing and 4 that are accredited by ANCC.
And again, let me remind those of you who have made presentations that have statistics, if you could make those statistics available, and particularly with the backup on where the statistics came from, that would be extremely helpful. Any other questions or comments by, yes?
This question is for Suzanne, Miss Suzanne Stone, or Dr. Suzanne Stone? Yes. Can you elaborate just a little bit on your diversity initiative?
Our diversity initiative was a HRSA-funded project, and we actually not only did we go to all of the Black Nurses Association, Asian nurses, and actually recruit at their conferences, we also identified certain universities that historically had had a high population of underrepresented students in their undergraduate nursing programs. And we went out to those nursing programs and made presentations to their students on the opportunities of advanced practice nursing. We did do affiliation agreements with several of those universities, and we're actually able to recruit those students, and because they really did not need to leave their home communities permanently, only for a few trips to Kentucky, we were able to enroll them in our program. We also hold a diversity weekend every May, and we've done this for 5 years now, where we bring in, it's actually voluntary, of course students can come or not come, but we fund them to come if they want to come, and we've brought about 60 of our students who are enrolled in our diversity initiative together with public speakers, nationally known speakers, and given them a forum to really discuss the issues of providing health care in their own communities. So the initiative is really to go into the community where they need health care providers and who represent those communities, and have those students graduate and continue to serve their own population. So it's been quite successful. We still have a lot of work to do.
Ed?
Question for Brittany on Broyhill. It's listed the director of the Association of Postgraduate APRN programs, and can you tell me what that association is and whether it includes most of the, whether you think it includes most of the advanced postgraduate APRN programs?
Yes, we're really excited about that, and actually Marcy is one of the founding members as well. APGAP is what we're calling it for short, and it's a sister organization for APAP, which is the Association for PA Postgraduate Training Programs as well. And so we're working in collaborations with the PA organization to navigate through a lot of the accreditation issues surrounding nurse practitioner and PA programs. And it does include most of the first founding members of NP fellowship programs and residency programs in the country. There's currently 77 on our last count of nurse practitioner fellowship programs. These expand obviously primary care, specialty care, urgent care, some of the other emergency room and surgical services as well. And there's 14 that we have on track to be starting in the next 9 months or so. The reason that we started this organization was so that we can network, share resources, standardize these programs, make sure we're working for a joint accrediting body that meets our needs, as well as to share tools for evaluation and networking. Mm-hmm.
Are these all one-year programs?
Yes.
And they're all funded by the institution in which they're housed?
Many of them have different ways of funding. Ours at Carolina's healthcare system, I can speak to more personally. We are self-funded. What we see on our return investment, and I'll be happy to share some more of that information and data with you upon your request, but we actually have our nurse practitioners as licensed credentialed providers. There's some fellowship programs right now that do not do that. They have their NPs listed still as trainees. But what we see on return in investment is in the first 3 months to 4 months or so, there is an uptick to where they aren't as productive and aren't returning as much on investment. But by the end of their program, we really are seeing that their productivity is perhaps even higher than someone, we're working on that data, perhaps even higher than someone who hasn't went through a nurse practitioner fellowship program, because of the protected time to learn, because of the support, and because of the social network. I think that's one of the greatest things about our fellowship program is that we start 28 fellows every 6 months. And I can't tell you the number of fellows that have told me that having that support group of other nurse practitioners transitioning at the same time in a new city, in a new role, just for that social support has been instrumental in their success as well as their satisfaction on being a nurse practitioner.
Karen?
This question is for Stephanie. I'm, as a sister from Massachusetts, I wanted to ask you about the role of hospitals versus physician groups. So I'm looking at different stakeholders in putting barriers to increasing scope. I've been told by a couple of chief nursing officers that they feel that hospital charters and hospital regulations can be more restrictive in some cases than law. And if you can give me a sense of where you see the biggest obstacles to progress, that would be helpful.
So thank you for your question. I think, in Massachusetts, we actually are making significant strides with some of the hospital systems. The major academic medical centers are actually being quite supportive to us. So as you look at the overarching organization, we're receiving support, but on the individual level and the committee level, and in terms of models of care that are being developed in certain places, we are finding that to be restrictive. And those are areas where an individual physician is, or a committee of physicians is assessing the request for credentialing for an advanced practice nurse and has the opportunity to determine whether or not it would be aligned with our education and training as state law permits. So I think you see a lot of variability in that, but I am finding that I am receiving significant support from chief nurses in the major academic medical centers to engage physician partners in conversation, and they are stepping out in what I think is actually a very meaningful way, which tells me that we're getting ready for change.
Stephanie, while you're up, I want to apologize. I can see where the confusion. We did tell you that you had 3 minutes, but then we realized we had more people than we thought, so we needed to move it.
No
But
worries.
I do worry because you're in Massachusetts and I may need your care.
But look, you already made a huge commitment to me, so that I came out better than I could have hoped. Thank you.
There you go. All right. Any other questions or comments by anybody? I want to thank everyone. These were very, oh, yes, you're right, quiet that you're not.
Quiet person.
Jack Needleman.
I have a question for Elaine Ryan. You mentioned the 8 states that you have succeeded in. There have been a number of states where you have attempted and not succeeded.
Yes.
And I'm wondering what you have learned about what arguments on your side work, what arguments on the other side work, what you've learned about coalition building, and how the strategy in the future is being affected and changed by what you have learned from both the successes and the failures to get the regulations or the legislation changed in states.
Yes, thank you. Time didn't permit me to cover all our failures. No, but seriously, one of our biggest disappointments this year was California, where we actually succeeded in one house to move scope of practice changes, but the others were, virtually shut out. And I think that our state office, working with a extensive group of stakeholders, set up our effort to educate and also to embrace other consumer groups that hadn't had their voices heard in the debate. We're coming back to California. We're not giving up. California and the consumers and frankly the dearth of providers and the need for increased access is really compelling us to make a different case. I think that some of the arguments that we're familiar are constantly this pitting professions against each other. As long as it's about doctors versus nurses, and not about consumers who need access to quality care, then we'll continue to lose some of those battles where, frankly, some of the support from those major entities run into campaign coffers. As you may know, AARP does not give any money. We give a lot of spirit, but we don't have any PACs. We don't give money to elected officials. And we're going on the sheer power of the consumer to make that case. We're optimistic. Michigan, we're still in legislative session and looking at scope of practice there for this session as well as some other states. So we're trying to change the dialogue. What we'll do differently, I think, is bring in, I think, more education into the state legislatures and frankly, businesses with us. It's as much a business consumer discussion as it is a discussion about professions. And people are delivering, as you know, and I won't go on and on because of my 3 minutes wouldn't permit, but as you know, people are demanding, consumers are demanding different types of care. And yet our outmoded regulations and laws are not contemporary with those needs. And I think when businesses and consumers get together, we saw the magic that happened in Minnesota, where Target was one of our lead coalition partners. They're being responsive in a different way. And I think once we get out of the outmoded, dinosaur-like views that these are immutable laws and regulations, we can start to really push ahead more concertedly on enhancing the quality of care for those who demand it.
Thank you very much. Did I miss anyone here? Again, I want to thank. Yes, did you want to say something?
I did, Dr. Altman. I just wanted to note that we have been able to reduce preterm birth by 2/3, low birth weight by 3/4, and cesarean section by 2/3. 3 studies from the Urban Institute have shown that if all births were managed on the model that we nurse midwives have developed with good medical backup and so forth, it could save in excess of $2 billion a year.
If you have the backup to that material and could make it available, that would be wonderful.
Yes,
Thank
I've
you so
asked
much.
Adrian to pass
Very
it to
good.
you.
All right. Well, thank you all. And excuse me. I can't hear. Oh, we have the video. Okay. I mean, people worked hard to put that video together, so I don't want to disrespect it. We'll try one more time.
5 years ago, when the Future of Nursing report was published, I felt pretty confident in my career. I knew that I was in a good place. I had a master's degree, and I'd already been the director of education for our health system for a number of years. So again, I felt pretty comfortable there. But what the report did for me was ignited maybe a passion that I'd always had. I knew I always wanted a doctorate degree, and I just maybe hadn't made that decision to do so. And really the report ignited maybe a spark to move forward and pursue that additional desire within my career. In 2013, I became the only DNP leader within our healthcare system, and that was such a proud moment and such an accomplishment on a personal level, but I think at an organizational level as well. I'm so excited to announce that we actually will have 7 DNP leaders by 2020, so I think we've more than exceeded the goal of doubling that percentage. Shortly after graduation, I was actually given the opportunity to start a new department, a new service that we had never really expanded into, and it was our community health department. And so I'm fortunate enough to be able to lead several of our Texas Medicaid 1115 waiver programs within that. They're each very innovative, very creative ways to approach population health, but each of them has really touched our community in a different way. Through our care transition program, we're actually able to navigate patients through a very complex healthcare system, and I think that's such a benefit for our patients. You know, we wonder why patients are readmitted or why they may perhaps be non-adherent to their care plan, but so many times it's lack of education and lack of that navigation through the system. So I think that we have a great opportunity to improve both the individual and the population level health through our care transition program. Additionally, I think that the Future of Nursing report and earning a doctorate degree really combined gave me that confidence and the skill set to move forward and lead initiatives well beyond our health system. And so now I lead 2 state grants, and each of them are focused on promoting health, but some at the population level and some at the individual level. So those grants have really given me the leadership ability to move beyond our traditional hospital wall and reach out into the community, partner with key businesses, nonprofit organizations, I mean, you name it, just a really good compilation of people coming together in a coalition effort to improve the health of our community. as a result of the Future of Nursing report, obviously the Texas team was created, and that has given me even more opportunities through this great network of leadership and mentorship to become more involved at the state level. So in 2014, I began helping to lead our Nurses on Board initiative at the state level, and that has been really successful. We're very proud to say that we held our inaugural class last July, and now we are holding our second statewide class this July with another class planned in September. So I think that our Nurses on Board initiative is so important at the state level, but also at the regional, local level, and so we're doing a lot within our community to promote it and to really prepare nurses to serve on boards and to lead, not only at the bedside, but in the boardroom as well. So I think that that's a great opportunity through the Future of Nursing to become more involved. So when asked the question regarding what the Future of Nursing report really did for me, I think that I can honestly answer it changed my life personally and professionally. 5 years ago, I was not the leader, the nurse, and the person that I am now, and I can only hope that in another 5 years, I won't be the person I am either. It has really changed my perspective on nursing. It pushed me, it inspired me to keep moving forward, to continue to reach out both to my profession and to my community at large, and to really continue to advance health in any way possible.
All appreciate it. Thank you.